Today we are going to discuss about part 2 of Surviving Sepsis Guideline 2021. Now, introduction. As we all know, sepsis and septic shock are medical emergencies, and sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. And septic shock is a subset of sepsis, which circulatory and cellular and metabolic dysfunction associated with an increased risk of mortality. And this definition remains same as sepsis 3 and 2016 guideline. So last day after 42, recommendation 42 has been discussed. So today we are going to start from the 43 recommendation. Monitoring and intravenous access. For adults with septic shock, we suggest using intravenous monitoring of arterial blood pressure over non-invasive monitoring as soon as practical and if resources available. Weak recommendation and very low quality of evidence. Estimation of blood pressure using non-invasive cuff tends to be inaccurate and discrepancy more pronounced in soft steps. Insertion of an arterial catheter permits safe, reliable, and continuous measurement of arterial blood pressure and allows real-time analysis. Not only that, the blood pressure line through this line we can collect the blood sample for other investigations like EBG, blood sugar, and other daily investigations. Arterial line catheter should be removed as soon as continuous hemodynamic monitoring is no longer required to minimize risk of complications. For adults with septic shock, we suggest starting vasopressor peripherally to restore the MAP rather than delaying initiation until a central venous access is secured. Weak recommendation and very low quality of evidence. Remark: when using vasopressor peripherally, this should be administered only for a short period of time and in a vein or proximal to the antecubital fossa. This is a new recommendation in 2021. It is not in 2016. Vasopressor have been traditionally administered via central venous access due to concern of extravasation, local tissue ischemia, and injury if it is administered peripherally. However, the process of securing central venous access can be time-consuming and requires specialist equipment and training that may not be available in under-resourced setting, leading to a delayed initiation of vasopressor. Now, and not only that, extravasation may occur more frequently if vasopressor are infused distally to the antecubital vein for administration of vasopressor for a short period of time. So now it is recommended to start vasopressor agents in antecubital vein or the proximal to the antecubital vein. And ARISE trial has shown that most of the patients had vasopression initiated via peripheral catheter achieved MAP of 65 mm mercury with a shorter time, within 1 hour of initiation of vasopression. And actually the thing is that the delay in the vasopressor initiation is associated with increased morbidity. Mortality. So now they have recommended to start vasopressin peripherally for a short period of time, which is usually 4 to 6 hours. Regarding fluid balance, there is insufficient evidence to make a recommendation on use of restrictive versus liberal fluid strategies in first 24 hours of resuscitation in patients with sepsis and septic shock who still have signs of hypoperfusion and volume depletion after initial resuscitation. Remarks: fluid resuscitation should be given only if patient present with sign of hypoperfusion. We have to remember that this is not about the initial resuscitation. As per initial resuscitation, we have to give 30 ml per kg IV crystal oil over first 3 hours. It is after that if there is a still presence of hypoperfusion sign and volume depletion, this is regarding that issue. The ongoing crystal oil and liberal or vasopressor early resuscitation in sepsis, the Clovers trial, and the conservative versus liberal fluid therapy in septic shock classic trial will show some light in this matter. And these publications will come around June 2022, and according to them, it is show some light in this matter. Later we can comment on the next recommendation of publication. So this is the new changes. It's not in 2020, 2016. And the earlier was there, the 43 guideline that for adult with septic shock was suggest invasive monitoring of arterial blood pressure, same as 2016. 44 and 45, that is the vasopressor peripherally starting on vasopression, and there is a insufficient evidence regarding recommendation use of restrictive versus liberal fluid strategy is the new one. Now ventilation, which is generally defined as PO2 of 55 to 70 with SPO2 targeting 82 to 92%, did not significantly affect the primary outcome, which is the number of the ventilation free days compared with the liberal oxygen therapy for ventilated patient in ICU. So mortality at 90 and 180 days did not differ. So, but there is a recent systemic review and meta-analysis of multiple clinical syndrome investigator found that a conservative oxygen strategy was associated with a lower rate of death in acutely adult than a liberal oxygen strategy. So, there is a controversy regarding that. So, some say conservative is better and another says liberal is better. So, at this point of time, there is insufficient evidence to make a evidence on this recommendation. Now, ventilation for adult with sepsis-induced hypoxemic respiratory failure, we suggest the use of high flow oxygen, nasal oxygen over non-invasive ventilation. This is also a quick recommendation and low quality of evidence. Although the primary outcome of intubation rate at 28 days was not different, but the study demonstrated that improved 90-day survival with HFNC compared with the NIV. And HFNC patients experience significantly more free of mechanical ventilation during a 28 days study period. HFNC has some advantages like it is non-invasive and not only that high concentration oxygen delivery interface that confers the warming and humidification of the secretion, high flow rate to better match the patient demand, wash out of nasopharyngeal dead space and modest positive airway pressure. NIV use can be associated with development of complications including increased risk of gastric insufflation, aspiration, facial skin breakdown, excessively high tidal volume, as well as patient discomfort related to inability to eat or effectively phonate during therapy. But the fact is that NIV may help to reduce work of breathing in selected patients. So, patient having need of support to reduce work of breathing, we have to give NIV. Otherwise, in case of hypoxemic respiratory failure, we can HFNC can be a better option. Could be a better option. Regarding ventilation over invasive or non-invasive, there is insufficient evidence to make a recommendation on use of non-invasive ventilation in comparison to invasive ventilation for adults with sepsis-induced hypoxemic respiratory failure. So, when directly compared to invasive positive pressure ventilation, NIV may be able to achieve similar physiological benefit including improved gas exchange and reduced work of breathing in selected patients, while avoiding complications associated with intubation, invasive ventilation, and accompanying sedation. So, if NIV is used for the patient with sepsis-associated hypoxemic respiratory failure, we suggest monitoring and early reduction of the work of breathing and close monitoring of the tidal volume. Protective ventilation in acute respiratory distress syndrome. This is same as previous guideline. For adults with sepsis-induced ARDS, we recommended using low tidal volume ventilation strategy, 6 ml per kg of predicted body weight over a high tidal volume strategy. This is a strong recommendation and high quality of evidence. So, clinicians should use as a starting point of objective of reducing tidal volume over 1 to 2 hours for initial value toward the goal of low tidal volume, 6 ml per kg predicted body weight achieved in conjunction with an end expiratory plateau pressure less than 30 cm of H2O. If plateau pressure remains more than 30 cm of H2O after reduction of tidal volume to 6 ml per kg predicted body weight, tidal volume may be reduced further up to 4 ml per kg predicted body weight. This is same as previous one. Now, respiratory rate should be increased to maximum 35 breaths per minute, tidal volume reduction to maintain the minute ventilation. So, no single mode of ventilation and pressure control or volume control has consistently shown advantage one another.
This is very important because we now have a lot of fancy artillery equipment, so diaphragmatic sensing, code chair, etc. But there are other modes, APRV, bi-level ventilation. But nothing has, shown that does anything to the mortality. So get yourself familiar, with the basic equipment that you have with the basic volume control and the pressure control mode, so that you know exactly what is happening. আর সবসময় একটা কোনো প্যারামিটার চেঞ্জ করলে ওটা যে অন্যান্য প্যারামিটারস কে এফেক্ট করে সেটা সবসময় মাথায় রাখতে হবে যে তুমি রেট চেঞ্জ করলে তোমার আই কি হচ্ছে, whether you've got a set IE or whether you've got fixed inspiratory time or a set IE ratio, how is that affecting? Because when the I টা change হয়ে যায়, how is that affecting the pressures, whether it is cutting out because it is touching the high pressure limit, etc. and the patient is not actually getting the time of volume that you said. মানে ওগুলোতে খুব রক্ত হয়ে যেতে হবে to deliver effective ventilation.
Now, for adults with sepsis-induced severe ARDS, we recommended using upper limit goal-up type pressure of 30 cm of SQ over higher type pressure. It is strong recommendation and moderate quality of evidence because as a reduced mortality is associated with reduced mortality and more ventilation-free days in patients managed with lower blood pressure.
How do you measure pressure?
Respiratory hold for 1 second.
Yeah, so basically if you've got pressure control ventilation on, তাহলে তো যে প্রেসারটা আছে সেটাই প্রেসার আছে, আর you can go by that. If you've got volume, then you've got your flow time and your sort of rest time, ওই সময় বা you can do an inspiratory hold and you will get the type of pressure. এখন সেটা যদি একটা not a deeply sedated paralyzed patient থাকে তাহলে তোমার করতে অসুবিধা হবে, that is easier to do it on a paralyzed sedated.
For adults with moderate to severe sepsis-induced ARDS, we suggest using higher PIP over lower PIP. It is a weak recommendation but moderate quality of evidence. Adults with sepsis-induced respiratory failure without ARDS, even that now they are suggesting to use lower tidal volume compared to high tidal volume ventilation. Weak recommendation, low quality of evidence. Because sepsis is an independent risk factor for the development of ARDS, and delay in diagnosing ARDS may result delay use of low tidal volume. So we therefore suggested that low tidal volume ventilation to be used in all patients with sepsis who are receiving mechanical ventilation. For adults with sepsis-induced moderate to severe ARDS, we suggest using traditional recruitment maneuvers. It's a weak recommendation and moderate quality of evidence. When using recruitment maneuver, we recommended against using incremental PIP titration strategy. This is a strong recommendation and moderate quality of evidence. In non-traditional approach, the lung recruitment has been done by incremental PIP levels followed by a decremental PIP titration according to either base respiratory system static compliance or oxygen saturation. Whereas traditional recruitment maneuver consists of application of sustained continuous positive airway pressure around 30 to 40 cm of HT for 30 to 40 seconds. Recruitment with incremental PIP is associated with increased 28 days mortality. For adults with sepsis-induced moderate to severe ARDS, we recommended using tone ventilation for more than 12 hours daily. It is strong recommendation and moderate quality of evidence. Patient with ARDS and a PA to FiO2 ratio is less than 200, the use of tone compared to supine position within first 36 hours of intubation when performed for more than 12 hours in a day should improve survival. For adults with sepsis-induced moderate to severe ARDS, we suggest using intermittent neuromuscular blocking bolus agent over the continuous infusion. It's a weak recommendation, moderate quality of evidence. Neuromuscular blocking may improve chest wall compliance, prevent respiratory asynchrony, reduce peak airway pressure and oxygen consumption. But means 2016 guideline, there was a weak recommendation for using a neuromuscular blocking agent infusion for 48 hours in sepsis-induced moderate to severe ARDS. Overall, continuous neuromuscular blocking agent infusion reduces the risk of viral trauma, but the effect of ventilation-free days, duration of mechanical ventilation, and ICU acquired weakness was unclear. So that's why this changed to, as it is not ventilator-free days, was improved with this. So now we are recommending use of not use the infusion of the neuromuscular blocking agent.
Sir, one very good which was which trial was done to say that they did not
Acute trial,
which one was for
continuous infusion. Rose trial.
Rose trial मतलब कि बोल रहा ना
Is that related early to no difference in 90 days mortality?
when inclusion issue मतलब what should be given? Live sedation with intermittent NMDA if required. And what is the advantage of this trial over this trial? And why people are accepting this trial? Because at this trial, 50% of the patients were in prone ventilation. Therefore, they were not sure whether this improvement mortality was due to NMDA or due to this. And in those trials, only 16% patients were in prone ventilation. So that was the advantage of this treatment.
Before, we use light sedation while we are paralyzed the patient.
So according to this trial, they are saying that we should go for light sedation.
This is very related to the human rights. I think patient has to be adequately sedated rather than using the word light or
Light sedation means patients sleeping, but when we ask them to very typically
Yes, but when we paralyze the patient, we
then
don't have any.
so I think they have to be reasonably well sedated if you have to paralyze them. Otherwise it is inhumane.
Because the sedation system is
Yeah, so you use a balanced approach, and I think unless your chest is 100% oxygen, very high heat, not likely to. You have difficulty ventilating the patient, so then you sedate, paralyze, etc. all that. But otherwise, in most patients in ICU, you don't need paralysis in most patients in ICU. In most patients, you can get away with very light combined anesthesia with a sedation, so that the patient is completely asleep, but you have response score there. That reduces a lot of the DVT of coma and pneumonia of coma outcomes. Better, but paralysis correlate actually you should have some sort of a protocol to you have to stop everything and wake the patient up a little bit and see what's happening to his neurology. But stroke out sorry?
You should do every day.
Yeah, you can do it every day, but if you've got somebody, they're and he's like completely not like we talk about impractical, but then for most patients, every patient is every day. Yeah.
Beginning ECMO for adult with sepsis induced severe ARDS, we suggest using venovenous ECMO when conventional mechanical ventilation fails in experience center with the infrastructure in place to support its use. We recommendation and low quality of evidence. ECMO actually this is also new recommendation 2021 guideline to use the ECMO in ARDS patient. So this is the chart regarding the changes in 2016 and 2021. So first and last one has been newly added, and that is the patient with sepsis-induced hypoxic respiratory failure. There is suggested using of HFNC over non-invasive ventilation and the venovenous ECMO for ARDS, which is not responding even after conventional mechanical ventilation. Now, adjuvant therapy, this is corticosteroid for adult with septic shock and ongoing requirement of vasopressor therapy. We suggest using IV corticosteroid. Weak recommendation, moderate quality of evidence. The typical corticosteroid used in adult with septic shock is highly hydrochloric and dose of 200 mg per day, given as 50 mg IV over 6 hour day or as a continuous infusion. It is suggested that this is common as the dose of norepinephrine or epinephrine more than 0.25 mics per kg per minute at least 4 hours after initiation. Actually, in 2016 guideline, it was they are suggesting to use IV corticosteroid only when after fluid resuscitation and using of vasopressor. If they are unable to achieve the proper amount, they are trying even start to use corticosteroid. But now they are telling to start IV corticosteroid little early, even after starting with vasopressor, it's up within 4 hours, at least for 4 hours, but not achieving the amount.
You see, the fact that you are starting vasopressor, it actually means that you have already fluid resuscitated the patient. So that is out of the way. And then you have started vasopressor and a troponin combination, when you give it a few hours and you've still not getting the adequate hemodynamic response. So early book day, not before you have done all that.
After at least 4 hours.
Yeah, and this is a very old story and a long story, and probably we have not seen the end of this story. Actually, right? As a high dose steroid slope of the dose.
What about the dose?
Yeah, the dose was 50 milligrams 6 hourly or other continuous infusion of 200 to 600.
It's a lot.
Model.
Yeah.
Second, but you see again, when you are setting up a trial and you got your primary endpoint, and your primary endpoint is not met, so it's a negative trial. People generally don't like negative trials. Then they look into the data of all these secondary endpoints, and then yes, they have found all this, and that is, it is also important. We realize as clinicians, but I think we will probably identify in the future by some methods a subgroup of patients who are going to definitely benefit more with this steroid, which we still don't know. We are still using it as a blunt tool. One thing is clear that no high dose steroids. That is the sort of low dose. What steroid? People are gradually gravitating towards hydrocortisone, so physiological steroid in this sort of a dose. Whether you give it bolus or intravenously, but there is still no conclusion about mortality benefits. It's not clearly shown, though the adrenal trial is pretty big.
So are you trying to say that this is a low dose steroid?
Yeah.
Yeah.
But for somebody with septic, that sort of thing. And in the earliest trials, people tried to do this ACTH response, etc. But I think that just adds complication. It makes your clinical pathway more difficult to find steroid levels themselves are a little bit difficult to interpret.
Well, no, but I would consider this to be low dose.
No, this is not low dose.
This is
There is high dose for human beings sitting there. But when somebody has got severe sepsis in shock, and probably their pituitary adrenal axis is, normal steroids in that will क्या होता है cortisol levels?
no, दिन में सिर्फ 15 मिली.
दिन में नहीं, पर septic shock में क्या होता है?
What I'm trying to say is that दिन में अगर 15 मिली में 10 गुना दे दीजिए 150 और ये 200 आप बोलते थे तब हो रहा है up to 300 इसलिए मैं सोच रहा हूँ. Immune suppression and then come into fungal infection.
Yeah. But no, they have shown that there are two major risks. One is surgical patients, they are worried about their wounds, and two is infections. And there was no significant increase in those two parameters in that last group trial. See, the original steroid trial, which was held in probably mid-70s, they gave doses like 3 milligram per kilo dexamethasone. Okay, that is imagine a 60 3 milligrams per kilo. They showed some survival advantage, but there were a lot of these infections, surgical wound healing problems, etc. And it was mortality benefit was not shown in the subsequent study. I mean, when we were house staffs, etc. at college, nobody died without getting big doses of dexamethasone. Verifiably, if they were also short of blood, otherwise, certainly a lot of decathlon they would get. Quite the initiate, like, when you local sepsis, etc., but generally it fell out of favor till you got that main big this century trial, Corticus staphylococcus. I think the 2002 or something, that steroid trial that came, which first showed 50 QDS, etc., with 10 milligrams of fluticasone. But again, that showed some mortality benefit also, but the later trials have been iffy. And yet, trials actually have a large number of patients, which probably more than the combined number of the earlier trials. And it has failed to show mortality benefit, but it has shown that dose is safe.
Now, you mentioned about fluorocortisol. With
No,
that
no,
amount of hydrocortisol, you don't need fluorocortisol.
You don't need fluorocortisol. That's true.
However, emergency department has got a preference for using entire prednisone. So when patients come back to the ICU, they believe we need to titrate.
Yeah, and see, as long as you keep in mind the relative potencies. So, 4 milligrams of methylprednisolone is equal to 5 milligrams of prednisolone is equal to 20 milligrams of hydrocortisone. So, if you're going to use 200 milligrams of hydrocortisone, then the equivalent methylprednisolone dose is 40 milligrams. Whereas they probably end up giving 40 milligrams 3 times a week, which is not what you want to. Yeah, so I've seen this happening a lot with the COVID patients also, where the next month's recommendation was 6 milligrams.
Only 6.
Yeah, so you got to be very careful. Steroid is definitely useful, it saves a lot of life, but it is a double-edged sword.
An updated meta-analysis found systemic corticosteroid to accelerate resolution of shock increased resolution period. However, corticosteroid increased neuromuscular weakness without clear effect on short or long-term mortality. So now come to hemoperfusion. For adult with sepsis or septic shock, we suggest against using polymyxin B hemoperfusion with recommendation and low quality of evidence. So hemoperfusion refers to the circulation of blood through an extracorporeal circuit and that contains an absorbent containing the cartilage. Now, polymyxin B hemoperfusion is the most commonly used, but it is not in third world commonly. In first world country, they are using hemoperfusion studies regarding polymyxin B, and the studies were mixed. Actually, response. Some studies say it is helpful, and most of the studies say it is not helpful that much. And according to them, as it is most costly and there is not that much evidence regarding to support this trial, support this issue, so they are suggest against using polymyxin B hemoperfusion. There is insufficient evidence to make a recommendation on the use of other blood perfusion techniques like combined hemoperfusion, hemofiltration, or hemoperfusion with hemofiltration or plasma exchange. It is similar same as 2016 guideline. For transfusion strategy in adult with sepsis and septic shock, we recommended using restrictive over liberal transfusion strategy. It is a strong recommendation and moderate quality of evidence. A restrictive transfusion strategy typically includes hemoglobin concentration transfusion figure 70 gram per liter. However, RBC transfusion should not be guided by the hemoglobin concentration alone. Assessment of patients' overall clinical status and consideration of extreme circumstances such as acute myocardial ischemia and severe hypoxemia or acute hemorrhage is required.
Yeah, so you see if you look at some of the early Schumacher trials where people were trying to optimize oxygen delivery. There, people aim for a hemoglobin of 10. Even this early goal-directed therapy, I think they've got the target of hemoglobin of 10. Now, why 10? Why not 12? The general belief was that if you have more hemoglobin, then you have more oxygen delivery. But if the blood viscosity increases, then the flow and the perfusion, etc. So 10 was thought to be the optimum. But if you look at this, sepsis studies, the figure we have is that we now know that you're adding a biological load. Blood transfusion itself causes inflammatory response, TRALI, etc. So unless your hemoglobin is less than 7, so the target is 7 to 9 is fine, unless patient has coronary artery disease. So yes, you've got your myocardial infarction, etc., where you have to keep it at least 9, otherwise the mortality increases. If somebody is bled, then you obviously give them blood. So that is different. But if you got a standard ICU patient, sepsis, ventilated, and he drops his hemoglobin because we know that bone marrow is affected. Unless it drops below 7, then you should perhaps avoid transfusion.
This is a recent study in transfusion recurring critically ill oncologic patient trial. 28 days after randomization, mortality rate in liberal group is lower, and 90 days mortality rate also lower in the liberal group than restricted group. Ideal transfusion requirement in critical care as TRICC trial demonstrated no difference in the primary outcome in both liberal and restrictive group. The restrictive strategy has been was determined likely regards to resource required, cost effectiveness, and health equity consideration. A restrictive strategy is feasible in low and middle income countries. The 2016 strong recommendation favoring the restrictive strategy is unchanged. However, the overall quality of evidence changed from strong to moderate because of that oncological study. Now, stress ulcer prophylaxis for adults with septic or septic shock who have a high risk for GI bleeding, we suggest using stress ulcer prophylaxis. This is a weak recommendation and moderate quality of evidence. Risk factor including coagulopathy, shock, and chronic liver disease. Venous thromboembolism prophylaxis for adults with sepsis or septic shock, we recommended using pharmacological venous thromboembolism prophylaxis unless a contraindication to such therapy exists. It is strong recommendation and with moderate quality of evidence. For adults with sepsis or septic shock, we recommended using low molecular weight heparin over unfractionated heparin for VD prophylaxis. Strong recommendation and moderate quality of evidence. Lower rate of VD following the administration of LLP compared to unfractionated heparin. For adults with sepsis or septic shock, we suggest against using mechanical VD prophylaxis in addition to the pharmacological prophylaxis over the pharmacological prophylaxis alone, with recommendation and low quality of evidence. In 2016 guideline, a suggestion to use combination therapy whenever possible. The previous study shows that no difference between mortality rate on the rate of DVT, VE, pulmonary embolism, and lower liver ischemia between these. Sepsis or septic shock and AKI who require renal displacement therapy, we suggest using either continuous or intermittent renal displacement therapy. It is a weak recommendation and low quality of evidence. In adults with septic or septic shock and AKI with no definitive indication for renal displacement therapy, we suggest against using renal displacement therapy. Weak recommendation and moderate quality of evidence. After considering the resources required, cost and health equity issues, the panel issued a weak recommendation against using of RRT in patients with sepsis and AKI for increase in creatinine or oliguria alone, and without other absolute indication for dialysis like urinary complication, refractory ischemia, refractory fluid overload, and hyperkalemia. Now, glucose control. For adults with sepsis or septic shock, we recommended initiation insulin therapy at a glucose level more than 180 mg per dl. This is same as previous recommendation, strong recommendation and moderate quality of evidence. Remark following initiation of insulin therapy, a typical target blood glucose is 144 to 180 mg per dl, same as previous. Now, further research is indicated to identify which technology, including electronic glucose management, continuous glucose monitoring, and closed loop system, can more safely achieve better glycemic control and lower rates of hypoglycemia, and determine the optimal glucose control for different patient population, including diabetic and non-diabetic patients, medical and surgical patients. Vitamin C for adults with sepsis or septic shock, we suggest against using of vitamin C. Weak recommendation and low quality of evidence.
It can become pretty popular. Another issue with vitamin C is that when you give vitamin C, your capillary blood sugar measurements are also affected. So you would get falsely high capillary blood sugar measures, and your patients can actually be hypoglycemic.
Bicarbonate therapy for adults with septic shock and hypoperfusion induced lactic acidemia, we suggest against using the sodium bicarbonate therapy to improve hemodynamics to reduce vasopressure requirement. Weak recommendation and low quality of evidence. For adults with septic shock, severe metabolic acidemia, pH less than 7.2 and Atkins score 2 to 3, we suggest using sodium bicarbonate therapy. Weak recommendation and low quality of evidence. In this case, actually 4.2% sodium bicarbonate they are using.
Yeah, there's two sorts of there's two sorts of sodium bicarbonates available. One is which is 1 ml is equal to 1 ml. And the other 1.8, yeah. And the other is where you have to give a lot in a smaller volume, which is 0. Yeah, something like.
So what do we have? 1 equal to
7.
No, we have the highest pressure. One that you use boluses for whatever. You can dilute it, I suppose, but you have to do a bit of mathematics.
Nutrition for adult patients with sepsis or septic shock who can be fed enterally with such as early within 72 hours initiation of enteral nutrition with recommendation with low quality of evidence. Early administration of enteral nutrition in patients with sepsis or septic shock has potential physiological advantage related to the maintenance of the gut integrity and prevention of the interstitial permeability, damping of the inflammatory response and modulation of metabolic response that may reduce insulin resistance.
So this is very important. This is something that we could do improvement. I think this has to be nurse-led. So if you are not feeding somebody, you have to actively, the default mode has to be feeding. You have to actively make a decision to why am I not feeding? When am I going to do the next feeding trial? Or what is my plan for feeding this patient? It is factorial. I think surgeons, especially the laboratory surgeons, they have a default, they have this penchant of giving parenteral nutrition. They think that, oh, okay, I'm getting nutrition to pass, but that is not the same we know for a long time now. So we have to get better at providing some enteral nutrition.
Sir, in septic shock, there is a concern regarding the cutoff of splanchnic circulation.
Yeah.
And so is
You see, like if you have very high doses of vasopressors, etc., the worry is that they will cause gut ischemia. You see, what is your normal gastric secretion per day?
1 liter around.
Probably a bit more, probably double of that. What is your salivary secretion? And what I'm saying is that putting 30 ml down to the larynx tube is not going to cause gut ischemia. You know what I mean? Trophic feeding is what I'm trying to say, not full feeding. So you need this has been around for quite a while. If you don't feed the gut epithelium derives half its nutrition from the lumen and half from the glass. So it undergoes necrosis and sheds off, and it allows for transportation of bacteria and toxins, etc., which drives the systemic inflammatory response syndrome, which is why the selective digestive decontamination, etc., is all being tried. So, but to protect that, you don't need to give full feed. You need to give just trophic feed. And then you can give supplemental parenteral feed on the basis of your calculation on the patient's environment. But you have to give something unless it's absolutely.
And will you please guide us regarding, say, an imaginary cutoff point of the vasopressor requirement after which we.
No, I mean if somebody has a severe gut ischemia and had a laboratory taken out and job and checked out, like
No, I'm not talking about those
so there's no cutoff like that. I mean that would be an anecdotal thing other than that. But I think we were planning to do doing a session on feeding one of our days. So we should have more information about
Clinical input in terms of bowel movement is that
the bowel sounds do not correlate. Most operatively, bowel sounds do not correlate. And again, the same thing. Have you ever rally?
So 10 to 15 ml or around 500 to 600 ml per day.
I mean, you can have a protocol wherever we work at 30 ml an hour is the lowest level that we start, which comes over at 50 ml. But if they after 4 hours they'll aspirate and see. And if you get more than 50% of what you have put in, then they'll hold for the next 4 hours and then restart after another 4 hours. That is like like a working pattern. And it's very important to involve your nurses. I think it would be nice to see some of the senior ICU nurses, more experienced ICU nurses, to be here in the meeting. So because এটা ওদের থ্রুতেই করতে হবে আমরা বলে দিতে পারি বাট
But they always wait for the doctor's orders.
sure. But you see again if she knows and believes, she will remind you if you forget to give the order. And there's both for proper access, feeding,
So for this aspiration, it says that if it's more than 500 ml, we should stop.
At more than 50% of what we put in. Yeah.
If it's less than 500, we should be prokinetics and continue with low dose.
Providing is important. Also, this post-pyloric feeding thing is also important many times. Because a lot of times there is just gastric stasis and that's coming out, but the small bowel sort of keeps coming around slowly.
Post-pyloric feeding in a septic patient who possibly is ventilated, is possibly technically difficult.
No, you just put one of the longer tubes and you give them metabolite mind 3 times a day, and after 48 hours, you take a chest X-ray, you would have gone in. And if you are otherwise struggling and you need to sleep, you can ask Dr. Toby to.
So I was referring to that.
Yeah, but that's the cost of the hassle, etc. But most patients, these tubes, they get soft at body temperature. They are not as stiff once they are in there. Once it's left there for a while, and you are giving a prophylactic, then it will go.
So regarding adjuvant therapy, the new changes that for adult sepsis and septic shock will suggest against using polymethyl supervision. Earlier there is no recommendation regarding this, and for especially sepsis and septic shock will suggest against using vitamin C. Now comes to goal of care. For adult sepsis and septic shock, we recommended discussing goal of care and prognosis with the patient and families over no such discussion. This is a best practice statement. For adult with sepsis and septic shock, we suggest addressing goals of care early, within 72 hours over the late, with recommendation low quality of evidence. There is insufficient evidence to make a recommendation for any specific standardized criteria to trigger goal of care discussion. Despite a lack of evidence, the panel recognized that discussion of prognosis and exploration of goal of care with patient and family is a necessary precondition to determine the patient treatment preference and providing a value of concurrent care. Palliative care for adult with sepsis and septic shock, we recommended integrating the principle of palliative care, which may include palliative care consultation based on clinician judgment into the treatment plan when appropriate to address the patient and family symptoms and suffering. This is a best practice statement. For adult with sepsis or septic shock, we suggest against routine formal palliative care consultation for all patients over palliative care consultation based on clinical judgment with recommendation low quality evidence. Inclusion criteria for ICU patient consists of a mechanical ventilation for 7 days, high risk on a palliative care screen, physician determination on that care should not be escalated or care should be withdrawn. Physician believe that the patient could die in a few days or days in ICU or within the 30 hours of transfer out of ICU. This is the criteria for palliative care consultation. Intervention compromise for formal palliative care consultation, a complex quality improvement project to improve end of life care, and the panel end of life care conference conducted by the intensivist according to specific guidelines along with the behavioral brochure. Overall evidence for routine formal palliative care. Intervention in ICU patient is low quality and provides mixed evidence of its benefit. Thus, the panel suggests against routine formal palliative care consultation for all patients with sepsis and septic shock.
See, there was a study. Basically, they looked at two things. It was the cost, and 80% of the cost is spent the last, on the patients. 20% patients who die. There's a lot of resource goes into looking after or doing things to people who you know are going to die. But this decision, they can't keep worried, maybe can predict that, etc. It's very difficult. And we are particularly bad at it. Actually, that is not we as doctors, we as a society in India. I mean, that যখন ছাত্ররা চলছে চালিয়ে যাওয়া কি করে আপনি যেটা ভালো বলেন সেটা করুন etc. যেটা মনে হয় সব করুন ডাক্তার সব করুন, it leads to a lot of futile care. The other thing is that here we don't have, most places we don't have closed ICU where the patients are all looked after just by the intensive care physician. Here we have like a semi-open primary physician which is surgeon whatever. And you see, if somebody has been looking after a patient and the patient has been operated or whatever has been under somebody's care for some time and then transferred to ICU and then suddenly a new doctor, যার সঙ্গে ততটা rapport নেই, তার কাছ থেকে acceptability টা কম. So this is something which the primary doctor of the patient has to deal with. Medical legal issues চলে আসে. আমাদের এখানে এখনো তো এই ব্রেক ডেথ আর এইসব নিয়ে কত সমস্যা আছে, ভেন্টিলেটর থেকে খোলা নিয়ে কত সমস্যা আছে. this is a battle that we will have to fight another day.
For adult survivors of sepsis and septic shock and their families, we suggest referral to peer support group over no such referral. Weak recommendation and very low quality of evidence. Peer support groups have been used to enhance the recovery from illness when survivors have long-lasting disability, but have only recently been used in critical care and sepsis. With increased recognition of post-intensive care syndrome in survivors of critical illness and their families, peer support represent a patient-centered approach to improve long-term outcomes. Models of peer support are numerous and include community-based in-person or virtual peer support, outpatient ICU follow-up clinics with the ICU peer support, and individual peer mentor. For adult with sepsis and septic shock, we suggest using a hands-on process of critically important information and transition of peer over no such hands-on process. With recommendation, very low quality of evidence. This is insufficient evidence to make a recommendation for using specific structure and the tool over usual and the process. So, hands-on intervention critically important critical inpatient have been evaluated in this transition of patient care like emergency department to ICU to ward and the hospital or home. And it appeared to result in more complete and accurate transfer of information without any undesirable effect. Screening for economic or social support. For adults with sepsis or septic shock and their families, we recommended screening for economic and social support, including housing, nutritional, financial, and spiritual support, and make referrals where available to meet these needs. Best practice and guideline statement. Low socioeconomic status, substance abuse, and poor nutritional status lead to poor outcome, and critically illness itself result lower socioeconomic post-illness. Additionally, living in a neighborhood with low socioeconomic status is associated with increased risk of sepsis, community-acquired bacterial infection, and death from bacteremia and host outcomes.
See, guys need to see CNC develop. Yeah. CNC develop কি লাগে? মানে ওখানে there is an office আর জায়গায় posters এর মতো আছে যে if you need financial assistance then you can apply. So they would make arrangements and এখানে হয় না অনেক কিছু কিন্তু অনেক কিছু হয়. And regarding okay, that's a Christian organization, but I think at the outside patient consciousness of it doesn't matter whether it's a Christian God or a Hindu God or God of there's a church and every morning you can hear the church bells and you can hear things being sung. It's pretty soothing actually. And the patient, I was there. Misfortune for they to have a surgical procedure. So, okay, I was on the trolley and they wheeled me out of the room. I was going to go to the theatre, and suddenly the trolley stopped, and all the sisters gathered around the bed and kneeled down and said a prayer. So that is emotional support actually. So, ওইটা ওদের কালচারে ওখানে ওরকম আছে। ওই জিনিসটা ওয়েস্টার্ন সোসাইটিতে অনেকটা আছে। So you do get it. You can ask for your hospital chaplain to what around your number. Hospital regular prayer space and a church, not a chapel, and a chaplain, or a chaplain to what around that. To come culture host of the terminal patient care, whatever they have to do, they do. It's nice, that emotional support.
And often the chaplain comes during the end of life.
They do bother because situation কথা হয় কথা বলে জেনে নাই তার কি position etc. Categorically.
For adults with sepsis and septic or septic shock and their families, recommended the clinical team provide the opportunity to participate in shared decision making in post-ICU and hospital discharge planning to ensure that discharge plans are acceptable and feasible. Best practice treatment. Shared decision making is a process in which health professional, patient, and their caregiver collaborate and in making decisions about the patient care options. It is associated with a lower rate of anxiety and depression and improved support of family caregivers. For adults with sepsis and septic shock and their families, we suggest using critical care transition program compared to usual care upon transfer to to the floor with recommendation very low quality of evidence. Transfer from ICU to general floor and discharge from hospital are both non-relevant period for patient with high frequency of medication error and information loss of sepsis patient with longer than the average hospitalization and higher comorbidity burden may be at a particular risk for poor outcome with transition. Discharge planning for adults with sepsis and septic shock, we recommended recounseling medication at both ICU and hospital discharge based medical practice. Hospitalization and ICU admission are high risk period for unintentional medical error, both continuation of medication for temporary indication and unintentional discontinuation of chronic medication. Medication recontinuation has been associated with fewer medication errors and may help to reduce hospital readmission. For adult survivor of sepsis and septic shock and their family, we recommended including information about ICU state, sepsis and related diagnosis, treatment and common impairment after sepsis in written and verbal hospital discharge summary based practice statement. For adult with sepsis and septic shock who develop new impairment, we recommended hospital discharge plan include a follow-up with the clinician able to support and manage new and long-term sequence. Best practice statement. There is insufficient evidence to make a recommendation on RD, that is 7 to 14 days post-hospital discharge follow-up compared to routine post-hospital discharge follow-up. And there is insufficient evidence to make a recommendation on RD cognitive therapy for adult survivor of sepsis and septic shock. Sepsis is associated with newly acquired cognitive impairment and functional disability among survivors. Long-term impairment in memory, attention, verbal fluency, decision making, and executive functioning may be linked to a variety of mechanisms such as metabolic derailment, cerebral ischemia, and overwhelming inflammation, disrupt blood-brain barrier, oxidative stress, and severe mycological activation, and particularly within the limbic system. Post-discharge follow-up, for patient survivor for sepsis and septic shock, we recommended assessment and follow-up for physical, cognitive, and emotional problems after hospital discharge. Best practice statement. There are insufficient data to suggest any specific tool to assess for these problems, and optimal approach will vary by patient and settings. For adult and survivor of sepsis and septic shock, we suggest referral to a post-critical illness follow-up program is available. With recommendation and very low quality of evidence. Post-critical illness programs have been developed as a means of training for and addressing multifaceted issues faced by ICU survivors. These programs are constantly well linked by patients and offer an environment to learn about challenges sepsis survivors face, as well as to pilot and test the intervention for enhancing recovery. And the last one, for adult survivor of sepsis and septic shock receiving mechanical ventilation for more than 48 hours or an ICU stay more than 72 hours, we suggest referral to a post-hospital rehabilitation program. It is also a weak recommendation and very low quality of evidence. These are the changes long-term outcome for both of care. This is more or less the last few things have been changed from the 2016 guideline. For adult with sepsis and septic shock, family recommended screening for economic social support, including nutritional, financial, and spiritual support, and make referrals to available the meter according to their needs. This is more the change between 16 and 2021. Next one.
The economic thing is easy. Critical care started about middle of last century. Polio epidemic, etc. And এক এক করে জিনিসগুলো অ্যাড হয়েছে, but overall critical care has also improved, তাই না? আর যে জিনিসটা মোটালিটি তখন whatever 50-60% ছিল এখন 20% এ দাঁড়িয়েছে, আর it is getting increasingly difficult যে তুমি একটা প্যারামিটার কি একটা ওষুধ কি একটা ইন্টারভেনশনের added benefit demonstrate করা in today's environment of rigorous studies. And no two patients are the same. There are other soft things that are different in medical patient. So what we have to do is club a lot of these parameters into what is called a sepsis bundle. And that will overall produce a greater impact. So, formally query or informally query, when you see a patient, you will have to tick those boxes in your mind or in the file. And when you write, you can write when you're giving a note with those parameters. And if everybody is doing the same thing, then you will be implementing your sepsis bundle in the ICU. The resuscitation bundle they should be having in the emergency. And that will show up to the way and involve the nurses. I think that is very important. Because intensive care is intensive nursing care. If they're doing things just like a pair of hands, it will be less effective. Very good. Thank you. Anything else? Please. Next one, we start at 10, should finish by 11. And the talk should be about 40 minutes. And we should have 10-15 minutes for a chatter. Take it from there. So, topics you try and be here for 10. Take it from there. Thank you.